And I will just say welcome to everybody who's joining us. I'm Alice Weingartner with the Community Care Network of Kansas. So glad that you've joined us for this fourth session of this series. This session will be covering postpartum. Um, as we've shared before, the session is being recorded. We'll send it out afterwards. There will also be an email that includes the slides. We are keeping your microphones muted. You can use the chat or unmute to ask a question during the question and answer time. There are CEs available for this series. And Carrie, are you pulling up the slides for that as well? Or am I just in the wrong view? I might be in the wrong view.
I can see it.
Okay, so it's me. Um, so follow those instructions to claim your credits through Weitzman Institute. And this can be done for each session, so you can get up to 4 credits for this series. So I'm going to go ahead and introduce Christina Carpenter for the last time. So thank you for being here, Christina. We really appreciate it. She's a physician assistant with more than 20 years of experience in healthcare. She has spent 16 years practicing outpatient OB and gynecology before transitioning to her current role in gynecology at Penn State University Health Services. In addition to her clinical work, she's also pursuing her Master's of Healthcare Administration degree at Penn State and will be returning to school in about 3 weeks. This is an academic path that's helped inspire her involvement in this whole opportunity. And she has done a similar series with the Pennsylvania Association of Community Health Centers. So, Christina, I'm going to hand this over to you and let you get started.
Thank you so much. I had to switch to a different view too. Can you guys see me?
Yes.
Okay, perfect. Thank you. All right, so let's talk postpartum care. I like to think of postpartum care as an ongoing process and not just a single encounter. Um, So many women think of postpartum as that like one sole postpartum visit that they have, and then they poof, magically life is supposed to be back to exactly how it was prior to becoming pregnant. And we all know that this isn't the case, and we need to keep fighting as clinicians for postpartum care for our patients, and not just a postpartum visit. We know there's so much more to it than that. You can go on to the next slide there. So this is that same disclaimer. I recognize these are recommendations. It's our job to educate patients about the recommendations, and we're going to meet them where they are, and help them meet these recommendations as best we can. We'll move on to the next one. So, the fourth trimester is a term that has been coined to help give meaning to those first 12 weeks after delivery. It's the concept that this is just as much a legitimate time of childbearing as actually being pregnant. We know that the postpartum period begins with the birth of the newborn, but when it ends is really much less defined. So, generally accepted is about 6 to 8 weeks because pregnancy induced changes of most organ systems have largely returned to pre pregnancy states. However, this does not include all organ systems. And so ACOG, or American College of OBGYN, does extend postpartum care to 12 weeks. And there are several schools of thought that really feel that the first year after delivery is a time of change and adjustment. And really, that first year should be considered the postpartum time period. Now, that gets a little hairy when people get pregnant again in the postpartum time period. So, again, the first year is where we're really trying to change our mentality and our thinking, to understand that changes are still happening. All right. So during the pregnancy, we need to start discussing a postpartum care plan, right? We need to let patients know that the postpartum time matters and that we're here for them after that. Scheduling the postpartum visit during the latter half of the third trimester may also be really helpful. Obviously, you can schedule it at the time of discharge from hospital, but if you schedule it at their 36 to 38-week appointment, some people have really found that to work for their system. Although you don't know the exact time that they're going to deliver, at least they have an appointment already scheduled. So if they forget or they're too busy or they're unable to schedule their postpartum visit, they already have this visit scheduled that's known to be after the delivery, and that will allow you to pull them in and get the right information, and rather than it just being a completely missed opportunity. Okay. So that infant, or I should say postpartum care plan, includes things like infant feeding and resources like lactation consultants, postpartum emotional health, postpartum physical recovery, anticipated medical providers that are going to be needed after delivery. These are all discussions that we can be having, hence why they're called anticipatory, in the third trimester before delivery even happens. Go on to the next one here. So in 2018, ACOG set out to really redefine postpartum care. Traditionally, in our society, postpartum care has been really minimal or non-existent for a lot of women. About 40% of women do not actually attend their postpartum visit. We know that these rates really are actually quite higher in populations with limited resources, which are probably a lot of the populations that we're working in. But the good thing is women do not have to see their delivering provider to receive this care. They can see us. They can see us as their primary care. So ACOG does recommend all women have contact with a provider within the first 3 weeks after delivery as what they're calling their initial assessment. And then they continue with ongoing care as needed. And then ACOG recommends this comprehensive postpartum visit no later than 12 weeks after delivery. And you can see that that comprehensive postpartum visit is similar to the postpartum care plan on the previous slide. So the goal is to set the precedent that the first time you're talking about these topics is not actually at the postpartum visit. This visit should really be a check-in on all of the components that we've already kind of discussed with the patient, and making sure that they each have been addressed and that there's a plan moving forward. And just as a side note, I didn't put it on here, but like the World Health Organization recommends a very different postpartum evaluation. They think that patients should be evaluated on day 3 postpartum, 1 to 2 weeks after, and then 6 weeks after. So you will see different schools of thought on when these visits are appropriate. We do tend to go clinically a little bit more towards ACOG. All right, on to that next slide. So we know the transportation, the ability to physically come for a visit is a barrier for a lot of our patients. We need to be creative, utilize other ways to check in with them. Some of those ways actually came about with COVID. That was, again, one of the positive things with COVID. On to the next slide. Let's start with a very common, impactful complication of pregnancy, maternal health, and that's mental health disorders. We're going to cover quite a few slides on this because it's such a big topic. On average, up to 1 in 5 expecting and postpartum women in the US will be impacted by a mental health disorder of some sort. You should be screening for depression and anxiety using very standardized, validated screening tools. Obviously, screen at the initial prenatal visit. We've talked about that. At least one other time later in the pregnancy, we also talked about that. And then at the postpartum visits. Before you consider initiating pharmacotherapy, this is standard of care whether they're pregnant or not. Please make sure you're screening for bipolar disorder. We don't want to make anything worse. If they have self-harm or suicide questions on their screenings that they did answer positively, you have to have immediate assessment to make sure that the severity, do they have a plan? What is the risk that they're actually going to act on this plan? You need to do that evaluation for all positive screenings. All right, on to the next. So screening universally recommended. I certainly do not recommend utilizing all of these, okay? I won't get into the scoring of them for the sake of time, but it's an easy find on the internet. Basically, you want to find 1 to 3 of these that you feel comfortable with the questions, you feel like it really gets the information you're looking for, how to score it, and then how you can make effective recommendations based on the results. So really, you just want to use 1 or 2, maybe 3 that you are comfortable with and that you can work through pretty efficiently, and then just kind of get that into your process. These can be completed at check-in or given by clinical staff while the patient's waiting on you, and then the scores reported to you as the provider. They don't have to physically be given by the provider. We're going to move on here. Some specific mental health concerns you may see in the postpartum period. We've all heard of the baby blues. This is a temporary condition. Up to 80% of postpartum women will have this, and usually caused by a sudden shift in hormones. We know these feelings, these sadness, these swings, crying episodes. The symptoms typically peak around day 3 to 5 postpartum, and then they will resolve within a few days. They generally do not go on past 2 weeks. So that timing is important to kind of continue to monitor. Because if not, we start to move into maternal depression, which is really a major depressive disorder with the onset during pregnancy or within 4 weeks of birth. Okay. Clinically, you will see this term maternal depression applied to depression occurring within the first year after birth. So you sometimes can see that discrepancy. You're going to utilize the same diagnostic criteria that you use to diagnose depressive disorder in women who are not recently been pregnant. So this is bread and butter for you. You know these things. 20% of women will experience clinical depression during and or after the initial part of their pregnancy. And really, it can range from mild to severe. Symptoms are listed for you there. You know that the symptoms of depression are much lengthier than this and what you need to be looking for. And move on to that next slide. In terms of treatment, first line treatment for mild to moderate, not bipolar major depression is psychotherapy. Utilize pharmacotherapies, perfectly fine. You want to do those using ones that maybe were successful for the patient in the past, if they've been on something in the past. A lot of primary care providers worry about lactation safety, and patients do as well. And I would recommend utilizing apps or familiar resources in regard to that. We talked about them in one of the prior slides, if you look back. The risk to the infant from exposure through breast milk to most antidepressants is relatively low. This can be a really difficult conversation. Some patients will not take the medicine because they are breastfeeding. So you have to really kind of sit down with them and discuss the literature, not in a medical, not using medical jargon, but in their realm, and talk about the safety profiles. And one of the big things to discuss is the risk of untreated depression on her and mom and the baby, and how that may actually be more harmful to the baby, because usually that's what they're most worried about, than not doing something like medication. So please have that conversation if needed. You can also present an option of stopping breastfeeding to begin the medication if she really, really is very concerned about it. And that really is sometimes an internal struggle that you'll have to kind of walk through with the patient. Other things, obviously, we know for depression, consistent sleep-wake cycles as best you can. Nighttime support, I usually recommend if they're struggling, trying to have a support person that would be available, whether that's a spouse, sometimes it's not, because maybe they go back to work or whatnot. I usually say at least 2 nights a week, or 2 nights a week, try to have someone who comes in to watch the baby during your sleep time for about 4 hours. So I'm not asking moms to get 8 hours of sleep a night. We know that's really probably not reasonable, especially with some tough babies, but trying to aim for like 4 hours of consistent uninterrupted sleep is huge. So if they can do that like 2 to 3 times a week using outside help, that's huge. Okay. All right, on to the next slide. Maternal anxiety, that excessive fear, worry, nervousness. Obviously anxiety is something we all have, but really you have to look at its effect on quality of life, right? Are they not leaving the house because they are afraid of harm to the baby in public places? Are they staying up all night because they're so afraid of SIDS? Not being able to leave the baby with anyone else, even to shower, so they won't even leave into a different room. These are things you want to kind of be watching for. Really recognize that this is also often combined with depression or maternal OCD. Okay. You can see here maternal anxiety treatment really similar to maternal depression, right? SSRIs are appropriate when pharmacotherapy is needed. Benzodiazepines can be used while breastfeeding. Do note that ACOG recommends against their use or really using them sparingly. So low dose, short period of time, really reserving the benzos for a bridge to that long-term medication. Sometimes we do need them. Ironically, the American Academy of Breastfeeding Medicine advises that individuals may safely breastfeed while taking a benzo. So typically the razapam is most recommended if you do use it, as it's less likely to cross into the breast milk and there's less addiction and withdrawal symptoms. So lorazepam is typically the one that's used, if at all. And again, it's for a short period of time as a bridge. All right. So risk factors for depression and anxiety, postpartum, we know all of these things exist, right? This sudden change in hormones after delivery, the lack of sleep, for some patients, a difficult delivery or baby having health issues will really, really play into this. Trouble breastfeeding. I am just amazed still in my career how many women really struggle with not being able to breastfeed, and how much self-blame there is there. And so, make sure you're picking up on that. Network support doesn't always mean lack of support or that support is not present. So I work and live in a community that has a lot of international patients, many, many different cultures, especially with Penn State being here. It can also mean this very overbearing support. So we have in many, many other cultures, family comes in to help. And here, some of these patients struggle because they've been away from their family for so long. And now, mom comes from China for 3 months and stays with them. And some are helpful, some are not. Some insist that, the baby's being cared for a certain way when maybe it's not how the patient wants to do it. This can really cause them some significant distress as well. So just be on the lookout. It's not always lack of support. Sometimes it's an overbearance of opinions and support. Okay. All right, moving on to that next one. Maternal OCD, we talked about this just a little bit back with anxiety. So these are these unwanted intrusive thoughts that the patient has the urge to relieve through an action or a compulsion. And about 50% of patients with maternal OCD have intrusive thoughts about intentionally harming their infant. And about 70% of new moms have intrusive thoughts, right? So, although the content of the obsessions or the intrusive thoughts can be really quite scary, we need to remember they're not a psychotic process. The patient generally recognizes that the thoughts are unwanted, that they're inappropriate, that really causes them harm and fear, and it increases their anxiety. And again, this is why this is not a psychotic process. And we need to recognize that, and we need to reassure mom of that and how incredibly common these thoughts can be, right? There is actually an International OCD Foundation that has a part of their page specific to perinatal OCD. And so I do recommend, referring patients there if you feel like that could be helpful. Postpartum psychosis. This is one in about every 1,000 deliveries. It's usually a pretty sudden onset within the first 2 weeks of delivery. It does increase risk for maternal suicide and also has a 4% increased risk for infant death as well. Risk factors, obviously personal or family history, bipolar disorder. If mom has had a previous episode or psychotic episode, we know that this can also increase her risk postpartum. Treatment is going to be inpatient initially with then very close outpatient monitoring, okay, when that time comes. All right, we're going to move on here. Substance use disorder. Gosh, we know how common this is. Overdose mortality rates increased between 2017 and 2020 for pregnant and postpartum women. Really, really, we need to be during the pregnancy working and facilitating ongoing postpartum counseling, referrals to treatment facilities. It's great if you can have this all set up. Maybe someone's going to watch baby right after delivery and mom's going to go straight into a treatment facility. These are things that it's really nice to be helping that transition happen. There is also a school of thought of having a prescription naloxone on hand at home for these patients who are high risk for overdose. These are some of the contact information. You guys may have a lot of these already, but just putting them here for you in one place. Most importantly, I think we as providers need to put in the work and reach out to local counseling services in our areas, right? We need to establish that relationship for the sake of the patient. Case managers can really help us understand what providers in our community kind of pair with certain insurances, who's accepting new patients, who has reasonable availability. It's also helpful to know locations of providers that have specialties or have interests in postpartum concerns. Including also pregnancy loss and grief counseling. That's a nice one to have kind of in your back pocket too. If you, as the provider, can kind of reach out and have a toolbox of these people that you're already established with, and they know you and they know your screenings and what type of patient you're bringing to them, you're going to have a better chance, I think, of getting them in. You will find too that you will have certain patients who have experienced loss or in some way, shape, or form, something that your other patients would benefit from that support. There's certain people out there that are just really great at taking a traumatic event and making it into something beautiful, and they are great about leading support groups. And I want you to, as the provider, encourage them to create one, allow them to use maybe your waiting room space as, these meeting spaces. Encourage them to be that person in the community if you see that there's a need there and you think they would be a good fit. This slide is on here just to remind us that we need to consistently be screening for intimate partner violence, right? In 2018 to 19, the homicide rate for women ages 15 to 44 was 16% higher among those who were pregnant or pregnant within the past year compared to those who were not. We know that 45%, almost half of homicides to women who were pregnant or within 1 year of pregnancy, have been found to involve intimate partner violence. We know this link is there. We need to stay on top of it. For the health of mom and for the health of baby, there's tons of studies out there on long-term consequences to children based on intimate partner violence, not just to mom. And so we really, really need to be on top of this. All right, let's change gears a little bit and go on to postpartum hypertension, right? So after birth, blood pressure can do all of the things. It can decrease, it can remain the same, or it can increase. ACOG typically suggests blood pressure evaluation within about 72 hours of discharge in those who had severe hypertension during the pregnancy or even postpartum. And if you had someone who had like just non-severe hypertension, they recommend eval within 7 to 10 days postpartum. Okay. Patient could be doing home monitoring where they check it 1 or 2 times a day consistently for the first 2 to 3 weeks, and they're sending them to you. Sometimes that works as well. In generality, the blood pressure will typically decrease within the first 48 hours of birth, but it can increase again then like 3 to 6 days postpartum. So just kind of know where your patient is on her timeline in terms of what you would expect to be happening. Okay. The percentage of patients requiring blood pressure medications to maintain that 140/90 really varies based on their reason for the elevated pressures. So if they had chronic hypertension, 60% of those are going to require medications after the delivery to keep their blood pressures in a 140/90 range. And we might even want to pull it a little lower, right? If they had preeclampsia with severe features, 33%. In comparison to preeclampsia without severe features, 24% will require medications. If they had gestational hypertension, so pregnancy-induced hypertension, 16% of those are going to require meds afterwards to maintain their blood pressure. I put this on here in terms of analgesia. So the studies on acetaminophen versus NSAIDs are really up in the air. Some studies warn of this increased risk of hypertensive crisis with the use of NSAIDs in those with chronic hypertension. We know this. ACOG considers both acetaminophen and NSAIDs as first-line therapy due to their current evidence really showing no increased risk of hypertensive crisis with NSAIDs in our hypertensive postpartum patients. So specific studies looking at hypertensive postpartum patients are not seeing an issue. We do know that there are studies out there showing an issue with NSAIDs in those women who have not been pregnant. So do with that what you will. Most people lean a little more towards acetaminophen. Obviously, across the board, recommend the avoidance of opioids when possible. If you do need to use opioids, oxycodone and hydrocodone are probably the most commonly prescribed. We're really avoiding codeine, tramadol, especially in breastfeeding moms. So that kind of transient, new onset postpartum high blood pressure can be related to several things. There's this large amount of IV fluids that are given during labor, especially a C-section. That's going to change in that first 3 to 6 days postpartum that you can see these big changes. Um, you get this loss of like pregnancy associated vasodilation that we had talked about in the beginning. This happens after pregnancy. They lose that vasodilation. There's medications that were given other than just fluids. So those are things you want to keep in mind. Patients with new onset postpartum hypertension, you really need to get a good history taken, including like their postpartum meds, their fluid balance, their physical exam, checking their labs, their serum, electrolytes, their liver chemistries, their platelets, creatinine, urine protein. If they have abnormal lab values, neurologic things, cardiac, GI things going on, we need to think that maybe this isn't transient high blood pressure. Maybe this is something more, and we really should be looking into it a little bit more. Okay. Treatment here, obviously severe ranges, patient's going to need to be hospitalized for meds. 75 to 80% of women with gestational hypertension will see normal blood pressures within 6 to 12 weeks postpartum. If you have non-severe ranges postpartum, but you are consistently staying above 140 over 90, they do recommend either making sure they are on or initiating antihypertensives. Okay. Again, this is kind of referring to maybe someone who had no issues before and now they suddenly have it postpartum. Labetalol or nifedipine are your first line medications. There's meta-analysis out there on these 3 observational studies that showed lower rates of readmission for hypertension when discharged on nifedipine than labetalol. The findings are a little uncertain. Biases definitely played in. And so you will see people leaning a little more towards nifedipine, but labetalol is really commonly used though too. You're going to see it and it's not wrong. Okay. A caution I put on there with the methyl dopa, that postpartum or postnatal depression risk is there. You will sometimes see furosemide used postpartum, especially for like severe edema. Doesn't really have extensive data, but people do it. Basically, when you initiate the antihypertensives, you're going to usually keep them on them for several weeks. There is no set timeline based on the studies, and then you're going to slowly watch their blood pressures and see what they're doing. Clearly, if they're getting too low, you're going to start weaning them back down. There's a good chance your patient may not need to be on these lifelong if their only issue was in the postpartum time period. Okay. Beta blockers, calcium channel blockers are compatible with breastfeeding, although clinically you will see diltiazem used the most. Verapamil, atenolol, typically not used as first line, especially in breastfeeding moms. All right, postpartum preeclampsia. This accounts for about 5% of all preeclampsia cases, and it's usually within 48 hours of delivery. So I do bring this up in case you are seeing a patient maybe who delivered at home within that time frame. They could be developing postpartum preeclampsia. You need to be watching for that. Basically, if you have a postpartum patient who developed preeclampsia during the pregnancy, they're not going to be discharged early. They're going to be ones that usually stay. Again, these are patients who delivered in a hospital. They're going to typically have daily blood pressures for about 72 hours after the delivery. And then again, 7 to 10 days postpartum. That's probably going to fall on you because they'll be discharged at that point. Okay. Um, Okay, if they have new onset, sorry, I confused myself here. Postpartum patients with new onset preeclampsia, let's say you do have someone who delivered at home, there was no known issues with preeclampsia, they're coming to you within those first 72 hours or less, you've noticed something, you're going to need to admit them for the MAG-Sulf and monitoring for a minimum of 24 hours. And then you're going to begin those antihypertensives if their ranges are severe. Okay. And obviously, your point there is to prevent maternal stroke. You want to keep those pressures low enough. All right, on to the next one here. There are long-term risks associated with pregnancy-associated hypertension, and I think sometimes we forget that. And these are the risks. And remember that pregnancy-associated hypertensive disorders include gestational hypertension and preeclampsia. So the risks are particularly high if you have two or more pregnancies that are affected, or you have really like early onset preeclampsia and delivery was needed by like 34 weeks. There are also several meta-analyses out there that show the link between preeclampsia specifically and an increased risk for coronary vascular disease. Preeclampsia is a known risk factor for cardiomyopathy, both during and after pregnancy. American Heart Association actually considers preeclampsia or pregnancy-induced hypertension as they list it as a major risk-enhancing factor for developing cardiovascular disease and should be part of a patient and provider discussion about a patient's risk for atherosclerotic cardiovascular disease. Okay. So there are some really small studies out there that have shown patients with a history of preeclampsia, especially severe, also have an increased risk for mental health disorders like PTSD and depression. Some studies show an increased risk for cognitive decline later in life that happens at earlier ages, and also potential link with increased risk for autoimmune disorders. So I point these out to make you aware that the effects of pregnancy-induced conditions don't always end with the pregnancy, and we should be considering a patient's pregnancy history, just as we consider their past medical history as we continue to see them throughout their lifetime. All right. Let's move here quick to postpartum gestational diabetes. So that sounds a little counterintuitive, but most women with gestational diabetes, it will resolve shortly after delivery. If the patient was diagnosed with gestational diabetes, they need to have postpartum glucose screenings done, typically 4 to 12 weeks. It's a pretty decent range. You have time to check it. Basically, they're going to have a fasting plasma glucose and then that 75-gram 2-hour glucose tolerance test. Okay. But they do need regular screenings every 1 to 3 years because they have an increased risk for type 2 diabetes. And so we need to be screening for that. Okay. Lifestyle change is huge. We counsel on these all the time. Maintaining healthy weight, regular exercise, well-balanced diet, all the things. So early postpartum concerns. Let me check out the time here. Okay. Probably won't hit all of these, but I'm going to go over a few. So most postpartum headaches are not associated with a serious underlying pathology. A lot of sleep deprivation, hormone, dehydration, whatnot. But you must consider hypertensive related preeclampsia or severe hypertension or any sort of like acute like neurovascular event, or even a complication from their anesthesia when someone's coming in with headache that is just not presenting as you would expect. Okay. Postpartum hemorrhage is a primary postpartum hemorrhage typically occurs within 24 hours of delivery, but believe it or not, you can get a secondary postpartum hemorrhage that can occur up to 12 weeks after delivery. And those will kind of freak you out a little bit. If you have someone who delivered at home and is coming into you within the first 24 hours, be sure to palpate the fundus. It should be pretty firm and below the level of the umbilicus. Check their vitals, tachycardia, tachypnea, hypotension, all the things. Are they soaking a pad every hour, passing large clots? Did they have a slowing of their bleeding and now they have this sudden return of like heavy bright red bleeding? Okay. These are things you need to be asking about. Feeling light or lightheaded, dizzy, faint, short of breath, all of those things, right? Remember that uterine atony is your most common cause of postpartum hypertension. So you really need to be palpating that fundus. Fulminant colitis, keep in mind that there are antibiotics given a lot of times during the delivery process. Group B strep positive moms aren't the only ones getting some sometimes, so keep that in mind. Infection, this can be anywhere, but consider like their abdominal surgical site if they had a C-section, or the vulva and the perineum if they had like a forceps assisted delivery, episiotomies, tears. These all should be evaluated in that they could all become infected. Also think, your cystitis, your pyelonephritis, endometriitis, all of those things should be on your radar. Voiding difficulties, urinary retentions, you can get some damage to that pudendal nerve during birth. It can last 2 to 3 months after delivery. Some patients will notice that. Make sure that you palpate that suprapubic area for an overdistended bladder. Make sure you ask them if they are voiding. If they're unable to void for greater than 6 hours, usually this is a sign of some urinary retention that you need to do a bladder ultrasound for concerns. Hemorrhoids, treat those just as you would if they had not just given birth, although they can be quite intense, but all of the same treatments. Malodorous lochia is on here, and this one is interesting because the definition of malodorous can vary, but the most common cause is a gauze sponge that's left in after repair of the episiotomy or of the lower like genital tract. So please do a vaginal exam lightly, sensitively, but make sure there is no retained gauze in the vagina. Urinary and fecal incontinence will generally improve with time and are self-limiting. If they had a fourth degree tear and they have fecal incontinence, likely going to need to get them set up with a surgeon. Patients may commonly ask about pelvic floor muscle exercises. Personally, I think every postpartum woman should be signed up for postpartum physical therapy. In the first 2 weeks, it's usually not beneficial, may even actually cause some harm. So just be cautious with the timing on it. But I do caution patients on using online videos for pelvic floor physical therapy without having at least one visit with a pelvic floor PT first, because you want to make sure that everything feels and seems appropriate for them to be doing these exercises. We don't want to worsen anything. Okay. All right, let's go on to the next one for the sake of time here. So, delayed postpartum concerns. You can see gallbladder disease. This is typically caused by those pregnancy hormones kind of slow the gallbladder emptying, and then there's this usually rapid weight loss after delivery, and you'll see a lot of gallbladder symptoms pop up 2 to 4 months after delivery. Okay, appendicitis is another one, really common in the first 6 weeks postpartum, and these women feel like they got hit by a truck. Like I just had a baby, now I have my appendix out. It's a lot. It's a lot to take, but it's not uncommon. Remember, the thyroid can act a little crazy too. We certainly see those antibodies are really changing. Persistent vaginal bleeding. So really they should be finished bleeding from the delivery by about 8 weeks postpartum. Start looking for other reasons like infection, retained products, any sort of underlying bleeding concern if they haven't stopped by 8 weeks postpartum. Next, I want to just touch on a few concerns that patients will commonly ask about. Sexual dysfunction is one of the big ones, common in the first 3 months. Not uncommon, though, for patients to report this even into the first year postpartum. There's lots of reasons for this, be it, change in lifestyle, sleep, change in the relationship, all of those things. Vaginal estrogen can be helpful postpartum while hormone levels increase kind of those postpartum level or those pre-pregnancy levels. I'm sorry. There's no data that shows that vaginal estrogen is harmful to the mom or the baby. Usually we're using such a small amount. Usually, I say a pea-sized amount to the external labia. Sometimes we will do some internally, specifically if they had an episiotomy, make sure they're covering that area. Breastfeeding moms should be counseled in theory that it can decrease their milk supply, but there is fairly minimal absorption. And I don't see a lot of women with vaginal estrogen, especially if we're just applying it topically to like an episiotomy, have a change in their milk supply. So just be aware of that. Rectus abdominis, diastases, you see this a lot. Surgery is an option, but usually considered an elective cosmetic procedure. PT can help, physical therapy can help develop kind of a postpartum exercise program kind of targeted towards this. So that's always an option. Some women will wear an abdominal splint or like a binding device. The data on the outcomes of that is kind of limited, but a lot of women feel more supported. So you will see that happen. All right. Moving on here. So Leading cause of maternal mortality worldwide, postpartum venous thromboembolism. Very high risk in the first few weeks postpartum. Typically, that risk declines as they get to about 12 weeks out. Obviously, it is more common when the pregnancy is during pregnancy versus someone who is not pregnant. More common postpartum than the actual pregnancy itself. I know that's confusing. It is also more common C-section delivery than vaginal delivery, intuitive when we put in the surgical part of that. Okay. Treatment is listed there for you. Length of treatment, optimal duration is not really well agreed upon. 3 months generally seems to be what's most accepted. So this maternal allo immunization, I just bring this up so that you remember this if you have patients that are coming to you within 72 hours of delivery, and perhaps it was a home delivery, and maybe they didn't receive full care or they needed this and didn't get it. Just make sure you have it on your radar. All right, let's switch gears to lactation a little bit. Remember, we talked about starting to discuss this in the third trimester. And then we know that the most common recommendation is exclusive breastfeeding, right? This recommendation is backed by many large medical societies. Um, how long you breastfeed depends on which organization you look at, but our job is to inform the patient of this recommendation, support them in the choice that they make. Breastfeeding is not for everyone, and even some women who really want to do it are unable to for many, many reasons. So just make sure that you are supporting them as best you can in what's working for them. I don't think you need to go become a lactation consultant, but consider taking some online educational courses regarding breastfeeding, like techniques and complications. So, like the basics. Or if you're really interested, you could take it a step further, kind of reach out to a lactation consultant in your area. Maybe, you have the ability to travel to their house for an info session that you could then carry information on to your patients. But in return, maybe you would refer your patients to this person, this lactation. There are some online options, Nest Collaborative, Simply Fed, nestcollaborative.com. Is it Simply Fed? Yeah, simplyfed.com. Both of these offer telehealth services. So those are also places you could refer your patients to. Lactation mastitis, we know this is that firm red, tender area of the breast. Typically, there is a maternal temperature. They may also just feel awful. Sometimes they feel very, very flu-like. Make sure you remember your differential and looking into those things. Make sure we don't have an abscess. Continue for treatment. Make sure you have them continue breastfeeding or pumping, whichever they're doing. The worst thing they can do is stop. Okay. You can do NSAIDs or acetaminophen for pain and inflammation, cold compresses if they need the antibiotic. If you feel it is infected, cephalexin or dicloxacillin are your two most common. You can do Clinda in your penicillin allergic patients if you need to. All right, postpartum activity on this next slide. There's really no high quality data regarding what's okay, right? Most of this is just handed down information. So, climbing stairs, bathing, swimming, driving, resuming intercourse, exercise, working. These are all things that, patients really should be doing as they feel comfortable, right? And I put there kind of the differences in terms of vaginal versus C-section. As you can imagine, the more vigorous activity after C-section, we're going to hold off on a little bit. So reproductive planning. So you're going to begin these discussions in the third trimester. We talked about this a little bit last session. How many children do they want in general? How far apart do they want their children? How old are they? That definitely plays into it. You do want to try to get them to avoid at least 6-month intervals between those pregnancies, nothing closer than that if possible, just for overall maternal health. Remind the patient if they're not exclusively breastfeeding, ovulation can occur as early as 25 days after delivery. So if the patient is breastfeeding, ovulation can occur, typically later, a little less predictable, but they need to know they can get pregnant. Okay. So if a patient is breastfeeding, you're going to want to avoid the estrogen containing contraceptions until the milk supply is well established. Okay. Typically, that is thought of to be less than 30 days postpartum. When I was trained, we were actually trained to avoid the estrogen completely in someone who's breastfeeding. I would say that is still the case. I do avoid it in someone who's having trouble with a low milk supply, because I don't want to do anything to hinder their efforts. And so I will counsel them that that may be a problem, and I will say that it is their choice, but I support them if they don't want to do anything with estrogen right now. Okay. But based on the studies, really, as long as their milk supply is established, if they're over 30 days postpartum, they could do something estrogen containing. Okay. Other options, obviously, permanent birth control, permanent contraception, progesterone only pills. You have your standard norepinephrine mini pill, and then you have your drospirenone or your Slind. Don't have a lot of great coverage for Slind right now, insurance wise, unfortunately. Obviously, you have your LARCs, all of your long acting reversible contraceptions. Okay. I think I was going to talk. Oh, the permanent contraception. If their plan is to have a C-section and they know they want to have a tubal ligation, this is something you should try to pre-plan as well. Some labor and delivery units can complete that bilateral self-injectomy after the vaginal delivery prior to discharge. They usually do it within the first 24 to 48 hours. Some insurances, though, do require signatures at very specific times, and some insurances do have a mandated waiting period, and they won't allow them to do that. So just kind of know that. But male partner can be scheduled for a vasectomy usually anytime, even prior to delivery. So just remember that's an option, right? LARCs, these can be placed anytime after delivery. There is a higher rate of expulsion when the IUDs are placed directly after the delivery due to that enlarged uterine size. So if you can place it, a little bit out when that uterine involution has started, so 2 to 4 weeks after birth, you're going to have less chance of expulsion. But for some women, that's just not an option. We have to do it pretty quick after delivery. Beyond 6 weeks postpartum, the IUD perforation rates are higher in breastfeeding as compared to non-breastfeeding patients. You do want to counsel on that, but the overall perforation rate in both populations is really less than 1%. So it is a pretty small perforation rate to begin with, but breastfeeding does have a slightly higher one beyond 6 weeks postpartum. Progesterone only injection, we know this typically as the Depo-Provera. Single injection lasts for 12 weeks, acts as a great bridge for a 12-week postpartum visit for a patient that really you feel or they feel they don't have any other option. Perhaps they're going to be returning to intercourse, whether it's consensual or not, prior to their postpartum visit, and they really need to know they're covered. The Depo can be used in that situation. There is some conflicting info regarding Depo and postpartum depression. And so you do want to be just aware of that. Immediate use of Depo has been associated with a small increased risk of venous thromboembolism. Overall incidence remains very low. This is certainly going to be a risk-benefit type of conversation with very specific patients. I don't see Depo being used immediate postpartum nearly as much as it used to be. Let me see, let me look at time here. All right, so coming up on the end, only think a couple more slides here. So this goes back to the avoiding that estrogen initiation prior to 21 days postpartum due to the increased risk of venous thromboembolism. So now we're talking about adding that estrogen in. At first, we were talking about allowing estrogen because of its risk for decreasing breast supply or breast milk supply. In this situation, we're talking about avoiding estrogen up to the 21 days due to the increased risk of the venous thromboembolism. Just because I hate trying to remember all the numbers, I usually in my head will say 30 days, right? Try to avoid estrogen for 30 days and use other options if you can. Okay. There are different recommendations between the CDC, the World Health Organization, and ACOG as to when it is okay to begin estrogen. Okay. All right, that was actually the last slide. So contact information here and references at the end as usual, and hopefully a couple minutes for questions.
We do have time for questions. So Christina, thank you so much for this information.
Yep.
opening it up to questions if anybody has any that they'd like to ask about. We're all now experts in postpartum,
I hope.
or
I
at least
can
better informed.
I can tell you again, this is very, very interesting information. And while I'm not somebody that practices in a clinical setting, this is very relative to or relevant to what we're doing in our Transforming Maternal Health grant. And it validates everything that I've been hearing at this conference today and over
Yeah.
the last 6 months. So I appreciate you spending the time with this.
Yeah, I love it. Postpartum is such a place for us as primary cares in these communities to be helping patients. There's so many different parts of postpartum care, from the intimate partner violence to the mental health, that gets so pigeonholed towards um, OBGYN, and it doesn't have to be. And there's so much we can do.
So
Well, I think go ahead, Allison.
I was just going to ask, do you have any kinds of any thoughts about working with doulas or community health workers or um, care coordination? Anything about that that speaks to you or you can offer some insight on?
100%. I think that any resource that we can get to a patient in any way, shape, or form is needed, right? We know that if we just want to use just physicians, there are not enough physicians to go around. And we have to be able to meet these patients where they are. And I feel that our advanced practitioners, our doulas, our lactation consultants, they all have such a role that we in the clinic are not able to fill because we're under such other constraints, time being one of those, that we have to use them. And I feel like we need to have positive partnerships with them in our communities to make this work. And if we do this as a team, our patients are going to be the ones who, sort I'm looking for. Um, our patients are going to be the ones who we care for, as we should be. Okay. So I think having that team approach is huge. And I really would establish, I would have lunch with your local doulas and whatnot. I would make sure you know them on a first name basis. Being able to pick up that phone and call is such a thing that we've gotten away from in medicine. And I think that our patients are going to benefit from it. And we need to do it, especially in these rural settings.
Yeah, that's helpful to hear. And I don't want to monopolize. I don't know if there's other people that have questions, but I could sit here and I could pick your brain for quite a while. Alice, do you have folks that are waiting on
We, I,
questions?
I don't have any other questions in the chat. I don't know if anybody else on the call has any questions. Otherwise, I say go ahead and ask your questions. And if you have one, please raise your hand and we'll come to you next. So Allison, fire
Okay.
away.
Okay, so this is a topic of great discussion among our team, and I completely understand if this is not a discussion you want to have here, but what about certified professional midwives? Any thoughts on that?
I mean, that's a great topic, and it's certainly something that I understand why there's talk on it, right?
Mm-hmm.
Um, as a PA, as a physician assistant, I know my role is different than an MD or a DO. And I think, again, this is the importance of having those established relationships and understanding the governing bodies within your state. What I don't want to work for a supervising physician that doesn't know what my licensing allows me to do. And I think that's important when you're, as a physician, establishing those relationships with the midwives. I think that certified midwives who have the appropriate training and know when it's time to ask for help is is a huge resource in our communities. It gets a little tough. We have a lot of Amish in our area. it gets a little tough when you have lay midwives, maybe who aren't on that same page. We've had several instances where working with lay midwives, I don't want to say several, we've had some instances where working with lay midwives, perhaps the patient was left to birth at home a little too long, and this then put the patient and the baby in a pickle. And when they present to the emergency room to the physician on call who's never even seen this patient, boy, is that an awful place to be, right?
Sure.
Those are the situations you have to avoid. And if you have that working relationship with certified midwives, I think that it is a very useful resource to have. And just like my physician knows, my supervising physicians know when I know when I need to ask a question. I know where I don't know the answer. The certified midwives have to be in the same situation.
Sure, sure. Well, it's definitely a tough topic out here, but we have a pretty significant rural area. Probably, I think we maybe have 6 counties that are considered urban. I think around that
Wow.
number, but the rest are um definitely rural. So there's definitely some challenges, for maternal health and getting moms and into appropriate places for delivery at the appropriate level of care, I'll say.
Yeah. And those are constant ongoing conversations, right? I think that
Mhm.
as delivering providers, sometimes midwives may get very, very comfortable with what that level of care is. Um, and I think as a delivering provider or someone who's giving care, and following maybe some different standards, that trust has to be there, that they know when it's appropriate to ask for help.
Sure. Well, I appreciate that. A lot of topics at hand here. So if you ever want to come out to Kansas and hang out for a while, we can spend some time together. Our team would love it.
We
Um,
should. I was raised military, so the furthest west I went was Nebraska. So I am used to flat, but I do like my mountains in Pennsylvania.
Absolutely. Alice and I are both military brats as
We
well.
are.
So
Yep.
yeah, yeah.
Very good. Well, thank you, Christina, again
Yeah.
for your willingness to present to our Kansas folks. And thank you to those of you that have participated in this series. We did drop an evaluation in the chat, and we do ask that you take a moment to complete that evaluation. It will also be part of the email that goes out after the series is completed, and we send the follow-up information too. But your feedback is really important to us in making sure that we're planning sessions that are of value to you. So, Christina, again, thank you. We just can't be more appreciative. I think it's important for us to recognize the role that the health centers have, and primary care really is the place where so much of this care can happen, particularly in a place where we struggle with, the specialist and, very focused care providers. So I think this is just a great opportunity for our providers to build their comfort in being good, maternal health care providers. So.
That's
Definitely.
right.
Thank you, Alice. I'm privileged to have been able to do it, and I hope that everyone finds the info useful.
Very much so. Alice and team, thank you for inviting us to this. It was great.
Well, glad you could participate.
Yep.
All right. Good to
Bye,
see you. Amanda, I
everyone.
didn't say hi. Hi, Amanda. Thanks,
Bye bye.
everybody.
Everybody have a good afternoon.
You
Bye-bye.
too.
Have a good day.